patient in non-cardiac surgeries. So today, Dr. Tejas Bandari, he's practicing as a cardiac anesthetist in Nanded. He will introduce to madam's biodata, and myself is Dr. Sachin Chandolkar, Secretary ISA Nanded. We are conducting this thing since our Platinum Jubilee celebration year. So this one is 42. We will planning to complete this 75th case meet till then. And this one is all overall we are doing on private practice forum point of view case meets. So, and this one will be uploaded on our ICA YouTube channel, that is ICA City Brand Nanded. Ma'am, you are on now.
All right.
Yes. Are you able to share? Na?
Yes, I will be able to share. I'm sure I should not have a problem.
Yes.
Good evening, everybody. To start with, I would like to thank Dr. Sachin Chandolkar and Dr. Prahlad Kotkar for inviting me for this webinar on this very important topic. If you see today, even...
Ma'am, previously, should I introduce yourself through Dr. Tejas Bandari? Then you start with your...
Okay.
Lecture. Yes. So, Tejas, please.
Good evening, everybody. It's a great opportunity. Thank you, Chandolkar sir and Kotkar sir, for asking me to introduce the legend of anesthesia, one of the legend of anesthesia. She is Dr. Indrani Hemant Kumar Madam. She has a vast experience of 31 years. She is HOD and Professor of Anesthesia in KEM, Mumbai. She is a first rank holder in her post-graduation in DA and MD Anesthesia in Mumbai University. She is a fellow in cardiac anesthesia from Lehigh Valley Hospital in Pennsylvania. She has 42 publications under her name. She is also member of Special Board of Anesthesia in NBEMS New Delhi. Also a specialist board member for BLS and ACLS modules in MUHS. She is a governing council member of MS CISA for 2 terms. She is a past governing council member for Association of Medical Consultants, Mumbai. She has organized masterclass every year for residents all over India. And we were one of the residents when Madam had organized such class. She has also organized innumerable workshops and CMEs. She is She has trained in simulation and conducted simulation workshops. She is examiner for MUHS and universities in other states. Also, her main interest is in obstetric, pediatric, cardiac anesthesia, and critical care. She was president RSACP National and past president in ISA Mumbai. She was also president. She was member in ISA National Task Force for COVID. Also ISA Task Force Committee for CPR. She was member of Transplant Committee for KEM Hospital. She was also a member of Critical Care Committee of KEM Hospital for fighting against COVID. She was organizing chamber for ISACON in 2000, chairman in 2011 for ISACON. She has received Bharat Jyoti Award and Nitya Kalamani Award. And thank you, ma'am, to share your views today. Thank you, and I invite you on behalf of our President, Dr. Kotkar, and Secretary Dr. Chandolkar sir, and ISA Nanded. She will be discussing on anesthesia consideration in patient with coronary artery disease for major non-cardiac surgeries. A very important and very vast topic. Thank you, madam.
Thank you, Tejas. Thank you, Dr. Kotkar, President ISA Nanded, and Sachin. Sachin was my student, and I'm really happy to be part of this webinar. So let me just start sharing, sharing my presentation. All right. Visible? Let me go.
Yes, clearly. Let's start the slideshow. It will be working now.
Yeah. Visible now?
Yes, ma'am. Yes, it's visible.
All right. Friends, the topic for today is anesthetic management of an ischemic heart disease patient presenting for non-cardiac surgery. So you know that in modern times, with the type of life we have, patients of 20s and 30s are coming for percutaneous interventions, coronary interventions, and for CABGs. So if that is the case, the kind of patients who will be presenting with ischemic heart disease for non-cardiac surgery is only going to increase. So how are we going to manage? So what is the problem basically? Because of ischemic heart disease. I'm not able to run the slide. 1 minute. Let me just check. I think my slide just stopped. 1 minute. Let me check. I'm just trying to share again. The whole thing just... Sachin, are you able to hear me now?
Yes, ma'am. You are clearly
okay,
visible
I'm just
and
trying to
audible
share
also.
the screen all over again.
Yes, yes, yes. No issues. It's visible now.
Yeah, okay. I'll get it to slideshow. The whole thing just... okay. All right. You must be wondering why. Because patients with ischemic heart disease undergoing non-cardiac surgery, they are at increased risk for perioperative cardiovascular events like myocardial infarction, heart failure, or even death. So when you look at a patient of ischemic heart disease in the preoperative period, how do you approach that patient? First is you have to evaluate the current medical status, and then you have to evaluate the risk. Second is to know the risk-benefit equation. So I'll come to the risk-benefit equation as I come further down, because you'll have to tell whether does this patient require revascularization before the non-cardiac surgery or not? So what is the risk if the patient does not undergo any coronary intervention, or what is the risk if the patient undergoes coronary intervention and then comes for non-cardiac surgery? And thirdly, an advice regarding revascularization. That also has to be considered in the preoperative period. So coming to risk stratifications. So what are those things which increase the risk? One is advanced age, male gender, diabetes, non-invasive tests with high risk results, clinical instability, LV dysfunction, and if the patient has multivessel disease or left main disease. So the risk-benefit equation is whether the patient should undergo maximal medical therapy and then come for the non-cardiac surgery, or patient should undergo myocardial revascularization before. So an advice regarding revascularization should be done to reduce the fatal and non-fatal cardiovascular events in high-risk patients presenting for intermediate and high-risk procedures. So I will be talking about those things. when an unacceptable level of angina or congestive heart failure related symptoms persist. So these are the patients who will say, I get breathless even if I go to the toilet. So if that, or I get chest pain even if I go to the toilet. So if that kind of unacceptable level of angina or heart failure persists, then you have to think about revascularization, or when the patient experiences troubling side effects from medication. So what is the general approach? So you have to involve the cardiologist or the primary care physician, of course, the anesthesiologist and the surgeon, because a good preoperative evaluation means good outcome. So a proper and a thorough preoperative evaluation is needed in these patients. So how do you stratify the risk in these patients? Get a good history, do a good physical, do tests like ECG, labs. Some of them should have selective stress testing. A 2D echo has to be done. And in patients who cannot walk, like ortho patients, you can do a stress echo, and clinically indicated catheterization or a CT angio or a perfusion scan. So how do you minimize the risk? Preoperatively, risks can be minimized by giving the patient beta blockers, correcting the anemia, on a risk-directed PCI in these patients, and clinically indicated CABG if needed. So in the preoperative period, how the clinical evaluation should be done to identify serious cardiac disorders like presence of heart failure, arrhythmias. You have to define the severity, stability, and the prior treatment. Presence of comorbid conditions, again, very, very important, you have to evaluate in these patients. Presence of diabetes mellitus. If the patient has peripheral vascular disease, be rest assured this patient has coronary artery disease. If the patient has renal disease, again, there is a very bright chance that this patient has coronary artery disease. Presence of COPD. All these have to be taken into account when you're doing a preoperative evaluation. We will come to know that more the number of comorbidities, more will be the risk of surgery in these patients, anesthesia and surgery, and minimizing the risk, that is giving a standard treatment. So what we do is have a stepwise Bayesian strategy where you have a clinical markers to understand the severity of the coronary artery disease, prior coronary evaluation and treatment, doing a functional capacity testing, and surgery specific risk. So these 4 are the pillars of your preoperative testing. So the clinical predictors are divided as major predictors, intermediate predictors, and minor predictors. So the major clinical predictors are if the patient has acute or a recent myocardial infarction within 1 month, patient has unstable or severe angina, large ischemic burden. So these are the patients who have to go for stress test, decompensated congestive heart failure, or significant arrhythmias. At this point of time, I'd like to tell you, what do you mean by an unstable angina? So for just an example, that if I walk from my house to or if I walk from KM hospital to Tata hospital, which is very close by, then I get angina after I reach Tata hospital. That used to be there, that I know. If I put in that much of effort from KM hospital to Tata hospital, I get angina. But now I just come back from my OT to KM gate and I start getting angina now, today. That is unstable angina. So what was stable angina is now becoming an unstable angina. I hope you understood what is unstable angina. So what are the intermediate clinical predictors? A remote patient got MI several years back, stable angina, compensated cardiac failure. So the patient is treated now. Patient had gone into cardiac failure, but now nicely treated. Creatinine by about 2 and presence of diabetes. Minor clinical predictors, advanced age, abnormal ECG, rhythm other than sinus, history of CVA, and uncontrolled hypertension. So we come to the next one, which is the functional capacity. So if the patient has poor functional capacity, it only means poor cardiorespiratory reserve. So we all know, we ask the patient to how many flights of stairs you climb, right? So by that, we can make out what is the functional capacity of that patient. So here in a patient of ischemic heart disease, we need to give so much of emphasis to functional capacity. Remember, all your tests may be looking abnormal or normal, or rather normal, I would say. Even if your tests are normal, and if the patient is saying, no, I can't even, walk, say, 500 meters, then it means it's poor functional capacity, which means the patient is extremely high risk. Even your tests may all be normal, but still it is very, very high risk. So functional capacity has so much of emphasis in a case of ischemic heart disease. And please don't forget to find out what is the functional capacity of the patient. So we weigh the functional capacity by knowing the metabolic equivalent. So what is metabolic equivalent? A low metabolic equivalent, which is less than 4 METs. It means patient has very increased surgical risk. And intermediate METs is between 4 and 10 METs. You and me fall into this category of intermediate level of 4 to 10 METs. We are able to do our routine work, no problem. So that's intermediate METs. And excellent will be more than 10 METs. These are the ones who are athletes, who can really raise their bar and do a lot of things. So those who run marathons, they are all having a high METs, right? So what is low METs? Eating, dressing, walking around the house, dishwashing, all this will constitute low METs. Intermediate METs will be climbing flights of stairs, level walking at 4 meters per hour, scrubbing the floor, moving heavy furniture or golf. All these are golf. You don't have to run a lot. So that's intermediate METs. Excellent will be swimming, tennis, basketball, any of these athletes, all of them, all the athletes will have a high metabolic equivalent. So further preoperative testing to assess the coronary risk will be to know the surgery specific risk. So this again is important. We now know the patient has ischemic heart disease. We know what is the functional capacity of the patient. We know whether the patient falls under clinical markers. When you look at the clinical markers, whether they are minor, intermediate, or high risk. But now we are looking into the surgery specific risk. Surgery specific risk basically because of the hemodynamic stress and the surgical duration. So what are the surgery specific risks in these patients? The surgery will be considered a high risk with more than 5% mortality if it is an emergency surgery, aortic or other major vascular surgery, a peripheral vascular surgery, or a prolonged surgery with large fluid shifts, right? So intermediate risk will be the patient's risk of death will be less than death or presence of myocardial events, cardiovascular occurrence of cardiovascular events is less than 5%, like in carotid endarterectomy, endovascular AA and aortic artery aneurysm repair, head and neck surgeries, intraperitoneal and intrathoracic surgeries, orthopedic and prostate surgeries. And low risk procedures are peripheral procedures, cataract, breast surgery, again peripheral procedure, endoscopic procedures, all of them are considered as low risk surgeries. The risk stratification was proposed by a lot of people. Goldman proposed, Detsky proposed, Eagle proposed, ASA proposed. There are plenty of Canadian stratification is also there. But what's important for us is Goldman criteria, where he and the Lee's criteria. So here, Goldman criteria, he took into consideration certain comorbid conditions like the presence of recent MI, less than 6 months, unstable angina, heart failure, abdominal or thoracic surgery, severe aortic stenosis, emergent surgery, age more than 70, rhythm other than sinus, presence of S3 gallop, and other medical or metabolic problems. So and he gave a certain point to each of them. And then he calculated what is the total point, and then he gave the risk. So the points he gave was, if the patient had MI within last 6 months, it's 10, more than 6 months, it's 5, then unstable angina, 10. If the patient had class 4 angina, it's 20, pulmonary edema within 1 week, 10, and then critical aortic stenosis, 20. So like that, he gave so many points. And if the patient had more than 30 points, then the patient is extremely high risk. 20 to 30 intermediate risk, 0 to 15 low risk. Then we came to RCRI, which was presented by Lee, and this was the one which took the entire anesthesia fraternity to look into what Lee said, because he came with proper evidence. And this was published in the Circulation in 1999. And he took independent predictors like presence of high-risk surgery, history of ischemic heart disease, history of congestive heart failure, history of CVA, diabetes requiring insulin, and presence of creatinine more than 2 milligram per deciliter. And he said, he identified if the patient has only one risk or 2 out of these 6, 3 out of the 6, or 4 out of 6, what will be the prediction of post-perioperative myocardial events or even death. So what he did was, if the patient had only one risk, okay, so the mortality was less than 1%. If the patient had 0 risk, it is less than 1%. If the patient had one risk, then other vascular, there is, and surgeries, there is not much, but with aortic aneurysm, the risk becomes almost 7 to 8%. If the patient had two of those risks, which I just said, look at the steep rise in the incidence of morbidity and mortality. And finally, presence of more than 2, yes, it's sky high, risk of presence of post-operative cardiac events or even surgery. So if there was no risk factors, it is about 0.5% risk of death. So here he looked into rate of cardiac death, non-fatal myocardial infarction, non-fatal cardiac arrest according to the number of predictors. So if it was no risk, it is 0.5%. One risk is 1%. Two risk is 2.5%. If 3, it is more than the double. So if you have 3 or more risk, it is almost like double the amount of risk for the patient. And rate of presence of myocardial infarction in the perioperative period, or with the rate if the patient can develop pulmonary edema, VF, or a primary cardiac arrest or complete heart block. For that, again, he took the risk factors. If there was no risk, 0.5%, one risk is 1.3, 2 risk is 3.6, and 3 or more risk is almost like 10%, 3 times the patient having only 2 risks. So in the preoperative period, if the patient needs coronary vascularization, again, the question arises whether the patient needs a PCI or whether the patients need CABG. So what decides The cardiologist will be the main person who will be deciding on this. Again, you also have to see, depending upon whether what is the nature of surgery, what anesthesia you're going to give, what could be the possible complications, how high is the hemorrhagic risk, and what are the other individual hemorrhagic risk factors, what are the consequences of excessive bleeding, what is the urgency, can it be delayed, what are the alternatives to surgical treatment? All these questions have to be answered before you take up these patients for any non-cardiac surgery. So once, according to the ACC, American Heart Association guidelines, so the risk stratification will start by asking the question, is the surgery urgent, emergent? Yes. If the surgery is emergent, no need of anything, take the patient to the OR, because here is a patient who needs emergency surgery. Is it emergent means just now you have to take the patient? Is it urgent or is it elective? Then you look at the patient, whether the patient already had revascularization in the last 5 years. Yes, if the patient had revascularization and is not having any symptom, straight away take the patient to the OR. But if the patient has symptoms now following revascularization, then this is a patient who needs further risk stratification. Also, if the patient did not have any revascularization at all, you need to do further risk stratification. So look at the clinical predictors. Does the patient come under major, intermediate, or minor clinical predictor, the clinical predictors? If the patient comes under the category of major, you have to postpone the surgery. You have to postpone the surgery and do a coronary angiography, or the patient will need extensive medical treatment and risk factor optimization. If the patient comes under intermediate category, look at the functional capacity. Is the patient not able to do anything at all? Is the patient having less than 4 minutes? Is the patient not moving around inside the house? So then you have to do you look for further testing of these patients. So then you have to go for stress testing or stress echo or my perfusion scanning and things like that. So you'll have to do further testing on these patients. And if the patient is the metabolic equivalent is more than 4, and if the surgical procedural risk is high, again, you have to go for the same stress testing. But if it is intermediate or low, you can straight away take the patient to the OR, because here is a patient whose clinical prediction is intermediate and the surgical prediction is also intermediate or low. So here you can take the patient to the OR. If the clinical predictors is minor in these patients, then if the metabolic equivalent is low, then you look at the surgical procedural risk. If it is intermediate or low, you can take the patient to the OR. And if it is more than 4 minutes, again, a patient can go to the OR. So obviously if the functional capacity is less than 4, you need further testing. So this slide gives you in one look. On one side, you have the medical risk on this side and surgery specific risk on this side. So if those patients whose medical risk is major and surgical risk is low, intermediate, or high, low, intermediate, or high risks. Those who have medical risks of minor and intermediate, they are in the green, so which means they can go to the OR. Those who are in yellow and red and orange will need further testing. So which test to choose? If the patient is an ambulatory patient, you can go for a treadmill stress test or an ambulatory ECG. If the patient is having abnormal resting ECG, okay, then the patient will need echo or thallium. Patient is unable to exercise, patient will have to go for a DSC, adenosine thallium and a dipyridamole thallium scan, or a CT angio or a coronary angio, depending upon what the patient, the cardiologist will decide. How to monitor for ischemia? So according to the symptom, patient will complain of, usually, many times patient may not complain. Otherwise, patient will say chest pain, then symptoms of breathlessness, sweating, nausea, vomiting, altered mentation. Clinical signs, heart rate changes, arrhythmias. Patient will say, I'm getting, I feel my heart rate is raising, I'm missing some beats. So all these, or presence of hypotension. Patient's BP is only around 100, 110, 105. So persistent hypotension. In all this, ECG is a key intraoperative monitor. PA catheters, we don't use them nowadays. TEE is excellent, but again, only in tertiary care centers, you can have all these. Again, when you look at the ECG, the patients can have depression or ST elevation. Depression is if the patient has subendocardial ischemia, then the ECG will be of small voltage. Okay, so, and there will be poor localization. There will be a down sloping here from the J point. Here the J point is down and it is from the ST wave will start from the J point. So if there is an upsloping, then in ST elevation, you find that there is an upsloping of the T wave. So elevation generally means it's a very severe myocardial infarction. J point ST depression will signify that here is a patient who has myocardial ischemia, whereas those with an elevation, it means the patient is having myocardial infarction now. So let us look at the anesthetic management. Most ischemic episodes, especially in a patient with a known coronary artery disease under GA, is silent and it may be missed. A number of silent, repeated and prolonged episodes of ischemia may occur during intubation or extubation, proven by demonstrating acidosis in the coronary system. And patients with hypertension or CCF, it is possible that they can have episodes of subendocardial ischemia during the surgery in these patients. Why surgery is a stress? Surgical trauma, anesthesia, analgesia, intubation, extubation, pain, hypothermia, bleeding, anemia, fasting, all of them can trigger an inflammatory state, a hypercoagulable state, a stress kind of situation, and a hypoxic state. So with inflammatory state, you will find that a plaque which was stable will start fissuring. A hypercoagulable state is dangerous because these are the patients who can develop acute coronary thrombus. And a stress state is because there is increase in catecholamines and cortisol levels. There will be a shear stress in the coronary arteries and you can have fissuring of the plaque. And hypoxic state, there will be less oxygen delivery, patient's BP will go up, heart rate will go up, free fatty acids will go up, and there will be increase in relative insulin deficiency. All of them can lead to an increase in oxygen demand. That leads to perioperative myocardial infarction. So the prominent factors in the intraoperative period, which one should avoid, is hypertension, relative hypotension, that is any blood pressure less than 80 millimeter mercury should be immediately treated, tachycardia, bradycardia, and the anesthesia duration. So preoperatively, hypertension should be under control. Continuation of preoperative antihypertensive treatment is very critical. Consider the urgency of surgery and the potential benefit of more intensive medical therapy in these patients. And a myocardial heart disease, presence of dilated and hypertrophic cardiomyopathy, they are associated with increased incidence of STT changes and perioperative heart failure. So the preoperative controls, we can just talk in terms of A, B, C, D, E, whether give the patient aspirin, give the patient anti-anginals, alpha-2 agonists, all of them should continue. B is beta blocker and blood pressure, control the blood pressure, continue beta blockers. C is cigarette smoking and cholesterol and clopidogrel, stop cigarette smoking, cholesterol control using statins, and clopidogrel has to be stopped at least a week before. Fourth is diet and diabetes. Have a control on your diet and control on your diabetes, education and exercise. So these are the preoperative controls. So what is the risk reduction strategies in the intraoperative period? One is to ensure that you monitor properly. So here is a patient with ischemic heart disease. You have to step up your monitoring. Apart from your ECG, NIBP, temperature, ETCO2, SpO2 urine output, you have to monitor the dynamic indices in these patients. So stroke volume variation, you will see that the pulse oximeter graph is going up and down with respiration. We know here is a patient whose volume is less, hypovolemic. So you look at the dynamic indices in these patients. Not all of them will need an arterial line or a CVP. Those patients who are high risk clinically and coming for high risk surgeries, they are the ones who will need arterial line or a PA catheter. Or a CVP, not a PA catheter. So what are the emergency CVS drugs you will keep with you when you're dealing with a patient of patient of ischemia? So even in your private practice, ensure all these are in your basket. Ephedrine, no, you don't have to open them and keep it, but you have to at least have them with you. Ephedrine, phenylephrine, IV beta blocker, NTG, dopamine, dobutamine. So what are the goals? Goals, I'm calling it a crap. No, it's not a crap. Just that a mnemonic. C for contractility. So you'll ensure that the patient is contractility is good. Rate, keep a low rate, keep a normal sinus rhythm, maintain a low afterload, and maintain an adequate radio. So these are the goals of these patients. I just said the whole thing. So the intraoperative goals, as I said, is to look into the favorable part of the coronary demand and supply ratio. So this is one is to increase the myocardial oxygen supply and to reduce the myocardial oxygen demand. So how are you going to increase the myocardial oxygen supply? By maintaining a low normal heart rate, by maintaining proper hemoglobin, high normal aortic pressure, that is maintaining the blood pressure, reduced coronary vascular resistance, and low left ventricular end-diastolic pressure. And by decreasing the demand by maintaining a proper heart rate, low myocardial wall tension or afterload, and avoiding increased myocardial contractility, that is blood pressure. So this is the two sides of the equation, that is the oxygen and the oxygen supply and the oxygen demand. So on the oxygen supply, we have good coronary myocardial oxygen supply by maintaining hemoglobin, as I said, maintaining a good coronary blood flow by maintaining a good diastolic blood pressure, LV-EDP, patent coronary artery, and coronary vascular tone. And by taking care of the demand, by reducing the wall tension and increasing the contractility and reducing the heart rate. So these are the two sides of the equation that one has to take care of. I already spoke about this. So on the morning of surgery, patient has to be properly pre-medicated. You need to give a narcotic sedative pre-medication, fentanyl 2 to 4 microgram per kilogram or morphine 0.1 to 0.2 milligram per kilogram, along with midazolam 0.2 to 0.3 milligram per kilogram can be given. Anti-anginals, keep a patch or a spray ready with you. Beta blockers and calcium channel blockers have to be continued. Alpha-2 agonists, if the patient is on chlorridine, fine. Otherwise, you yourself can start dexmedetomidine in this patient as you take the patient into the theater. Perioperative beta blockers have shown to reduce the incidence of morbidity and mortality, and most of the patients of ischemic heart disease will come with beta blockers. So, what about patients with a coronary stent and non-cardiac, coming for non-cardiac surgery? So these are the patients you have to discontinue dual antiplatelet medication because endothelialization can take up to 1 or 2 years. So no test is there to prove complete endothelialization till today. The risk of bleeding and thrombus with surgery is very high, and you have to wait for at least 1 year for the elective surgery after a stent. So if the patient has ischemic patient has come with a stent, what is the assessment you'll have to do? Ask the patient, what is the kind of stent? Is it a bare metallic stent, which is generally not there nowadays? Patient will come with a drug-eluting stent or a bioresorbable scaffold system. A DES patient, you have to wait for at least 1 year. Bioresorbable scaffold system, if the patient has received, you have to wait for at least 4 to 6 months. And how many stents? Is it single or a multiple stent? Which coronaries were stented? Left main, LAD, RCA, circumflex? What is the position and placement? Is it proximal? Is it a distal or is it at bifurcation? What is the timing of insertion? I already told you about this. All these questions have to be asked. Again, revascularization, is it complete or are they residual blocks? So what happens is many of the cardiologists will look only into the culprit vessels and they will stent only one vessel. There will be 50% block in the other vessel, 40% block in the other vessel. So find out whether the revascularization was complete, and is the patient on antiplatelet treatment? Is the patient on aspirin, clopidogrel, dipyridamole, low molecular weight heparin, or UFH? So what is the duration of therapy? Has it been started recently? If the patient has been for a very long time, remember there is something called clopidogrel resistance. So these are the patients who will thrombose and develop MI in front of you. And aspirin also, for a very long time, if the patient is taking, patient can have aspirin resistance. So if the patient is on low molecular weight, you know when to stop. You can advise when to stop. If the patient is on UFH, you can again advise when to stop. Low molecular weight heparin, if the patient is on therapeutic low molecular weight heparin, you have to wait for 24 hours. So, and if it is UFH, you have to wait for at least 6 hours. So cessation of therapy, aspirin is never stopped. Clopidogrel is stopped. If the patient is having if the patient is having bare metallic stent, for 1 month, you cannot take up the patient. And if the patient is having drug-eluting stent, not at least for 3 to 6 months. So these are the patients who will receive clopidogrel continuously. Now, what are the increase in bleeding risk? So if there is an increase in bleeding risk, you have to stop clopidogrel 7 days before. And if the patient is on ticlopidin at least 14 days before. And if the risk is small, dual antiplatelet therapy can be continued. So here I'm talking of the surgical bleeding risk. If the risk is small, you continue dual antiplatelet therapy, and then aspirin is continued in both elective and emergency surgeries. And if there is time, you please convert the patient to UFH or low molecular weight heparin if there is time. And look at the proposed strategy. The proposed strategy is to stop clopidogrel at least 5 to 7 days before the non-cardiac surgery, admit the patient 3 days before, and stop. And you can start a tirofibaman or a UFH infusion. Stop the infusion 6 hours before surgery and go ahead with the surgery and restart clopidogrel on the first post-operative day. And elective patients, stop clopidogrel 7 days prior to surgery. And if it is an emergency surgery, you may have to give platelet transfusion. And remember, all of them will need mandatory platelet function testing. And if the patient is coming for, and if the patient already has an epidural, remove epidural catheter after the transfusion of platelets. Reinstate dual therapy early to avoid a stent thrombosis, and similar caution with CVP and A lines have to be taken. If the patient has come for an emergency with antiplatelet therapy, then the dual, if the patient is having hemorrhagic risk surgery, platelet transfusion has to be continued. If the neuroaxial block is necessary, mandatory platelet function testing has to be done, and platelet transfusion has to be given. TEG is a very good guide. So in all these patients, how much of platelet count is acceptable? A common invasive procedure where you can compress the hematoma, 50,000 is good enough. Neurosurgery should be more than 1 lakh. Ophthalmic surgery, more than 1 lakh. Axial regional anesthesia up to 50,000 is okay. Spinal anesthesia, 50 to 80,000. Epidural has to be more than 80,000 to 1 lakh. So the technique of anesthesia which has to be followed in these patients is, if you're looking at general anesthesia, no single anesthetic agent is the best agent for ischemic heart disease, mind you. So all of them, amongst the evils, etomidate is better because of better hemodynamic stability. Amongst opioids, high opioid anesthesia is always good because it maintains cardiovascular stability. But then the problem is post-operative ventilation. And of course, the need for anesthetic agents is much less if you're giving a high opioid anesthesia. Inhalational agents, most of them are known to cause myocardial depression. Some of them are known to cause even coronary steal. And neuraxial blocks are excellent, especially peripheral nerve blocks are excellent. And if you're giving neuraxial block as in spinal, remember, if you maintain a low level, minimum sympathetic blockade will be there and minimum hemodynamic change. But remember, if there is any hypotension, you have to quickly treat the hypotension with phenylephrine. So the anesthetic technique is to maintain the oxygen demand supply and to avoid ischemia. So your choice can be both general or regional or a combination of both. As I said, short-acting agents with least cardiovascular effects are preferred. For example, midazolam is preferred for pre-medication. Fentanyl is preferred as an opiate. Etomidate is preferred as an induction agent. Remifentanil is going to come into the market in India. And if we have remifentanil, that's going to really make a big difference in these patients who are presenting for non-cardiac surgery. Sevoflurane and desflurane is very good. Isoflurane is known to cause coronary steal. Weak uranium and rock uranium, any of them can be used. So the general anesthesia technique is maintaining, as I said, the demand supply, giving good pre-medication, proper induction, attenuation of laryngoscopy and intubation by whatever method you know, and maintaining a good anesthetic depth in these patients and preventing pain. So the maintain hemodynamics, strictly avoid hypotension or hypertension, avoid tachycardia, ensure good pain relief, because in pain, if there's tachycardia, the most probable reason is because of pain relief, because of pain. Avoid hypothermia. Again, I would like to stress this. Many of us don't take this so seriously, but remember, if the patient develops hypothermia, the incidence of myocardial infarction has gone up exponentially. Avoid hypovolemia or even hypervolemia. So regional anesthetic technique, you can use spinal epidural or a combination of both, central as well as peripheral blockade. All are welcome in a case of ischemic heart disease, provided they come under the any of these categories, even a high risk category, peripheral nerve blockade is excellent in these patients. But when it comes to central neuraxial blockade, you have to be very, very sure that the patient doesn't have a very high level and that patient does not develop to hypotension in these cases. So a Cochrane library, this was the publication. It's a review of 9 systemic review of RCT. It summarized the outcomes of neuraxial analgesia with or without GA versus GA alone in a patient. And what did they come out with? They said that neuraxial blockade alone reduces a 0 to 30-day mortality and decreases the risk of pneumonia in these patients, which means they are saying, go ahead with your neuraxial blockade. Right, you did everything you can. And suddenly you find the STT is starting sagging in your patient. What do? So the management overview is all this while the ECG was normal. Now suddenly the STT has started sagging. So remember, interventions are often implemented at the same time. So you have to establish a temporal relationship because the sudden STT change will not happen suddenly. Something has happened before. That is why the STTs are now changed. What preceded this development? That question has to come. So you assess the urgency of the situation, inform the surgeon, step up your monitoring. Now you start taking a central line. Now, if the patient is on a block, whether it is a central or a peripheral nerve block, so the patient, you ask the patient, wake up the patient and ask him, do you have chest pain, breathlessness, or you see whether the patient is sweating or if the patient is having nausea, vomiting. If any of them are there, remember, that means the patient is indeed having severe getting into myocardial infarction. You have to do something, and I'll tell you what to do. Is the patient continuously coughing under the block? Or patient is trying to wake up, patient is restless? Then that means please auscultate and see whether the patient is having any congestive heart failure. Is there any altered mentation? Suddenly the patient was nicely responding and now the patient is not responding. Or does the patient have heart rate changes, a new onset arrhythmia or hypotension? Did the patient, or when you were giving an epidural top-up, was it a recent top-up? Because you have to think, was it an intravascular injection or was it a total spinal? That has to come in your mind if it was a recent top-up. Was any new drug given? Like, for example, did you give an antibiotic? Or did you start a colloid like Hemixil? Or is it a cement, or was, then you'll have to look whether it could be an anaphylaxis. Any hypovolemia, did the patient suddenly bleed too much? Or if it is a laparoscopic surgery, is the patient having too much of hypercarbia? Or is the patient is having, as I said, sudden hemorrhage? Any hypothermia? We don't touch the patient in drop. We have to touch the patient and see whether the patient is having hypothermia. Is the breathing oxygenation adequate, or is there any drop in SpO2? All these questions have to be answered in such a patient. You secure the system. So you have to give proper FiO2, give adequate oxygenation, maintain the blood pressure. If the patient has bled, you have to give blood, optimize the volume and heart rate. You might have to give beta blockers in drop. As I said, you may have to give phenylephrine if the BP is low. Step up your monitoring, as I said, inform the surgeon and ask him whether there is any alteration in the surgical plan, whether you can do something to complete the surgery at the earliest. If the patient is in pain, consider a top-up, or if you feel that your regional has failed, you may have to give general anesthesia on this patient. Rapid return to normothermia, enhance it in, make sure that patient is having normothermia, make sure that the mandatory hemoglobin should be at least 10 grams %, and for the ischemia, a sublingual NTG, that is Sorbitrate can be given, or if you have a patch, you apply a patch, and if it is emergent with hypotension, you may have to start inotropes, and you may have to give IV NTG in these patients. And keep increasing the NTG. As I said, you may combine it with a vasopressor. Consider an acute coronary syndrome in these patients. Quickly crush some aspirin and give it to the patient. You may think of even giving heparin in these patients if the surgery permits. So which kind of surgery does not permit? Neurosurgery, ophthalmic surgery, spine surgery, and patients who come with prostatic surgery. These are the surgeries which will not permit heparin. Other surgeries, you may think of giving heparin, because here is a case of acute coronary syndrome. Continue beta blockers. Patient may need IV beta blocker. So if the patient is under general anesthesia, so here your patient can never participate in your questioning. So what was the precipitating cause? What happened now that the patient was normal all the while, and now the patient is having STT changes? So if the patient is having ischemia without any hemodynamic alterations, so please see that sympathetic modulation by giving good analgesia. Beta blockade, you can give alpha-2 agonist, you can give dexmedetomidine. Ensure there is normothermia. Just give sublingual nitroglycerin tablet, and put a nitroglycerin tablet on the patient, or an intranasal nitroglycerin or IV nitroglycerin. Any of them will help, because here the hemodynamic alterations have not happened on these patients. If the patient develops ischemia, STT changes accompanied by tachycardia, then you have to say what could have been the reason. Are they non-specific STT changes? Is it because of light anesthesia? Is it because following endotracheal intubation? Is it hypovolemia? Is it fever? Is the patient developing, CREPS? Is it because of heart failure, or is it because of pain? So if there is ischemia accompanied by tachycardia, please give esmolol, about 300 microgram bolus, and start an infusion. You can also give atenolol bolus or a metoprolol bolus. If beta blockade is contraindicated, you can give calcium channel blockers as an infusion. Bolus followed by infusion. Start dexmedetomidine in these patients, because you have to control the tachycardia by all means, not just with beta blockers, or you also have to use dexmedetomidine to control the heart rate. If the ischemia is accompanied by tachycardia and hypertension, so which means we have tilted the whole thing to an excessive myocardial oxygen demand. So look at the oxygenation, ventilation, see if the patient is in CCF, check auscultate the chest, verify what the anesthetics, whether it's administered. You may find that there is no volatile agent in your in the anesthetic system. The whole your desflurane or sevoflurane might have got exhausted. Selective beta-1 blocker is a drug of choice, like atenolol or esmolol. Calcium channel blockers can be given. NTG is added if control is not achieved. Remember, if you're giving beta blockers, you have to expect bronchospasm and heart failure, but selective beta blockers will not give you this problem. If the myocardial ischemia is accompanied by hypervolemia, which means you have infused too much of fluids, which then the problem is increase in fluid will increase the left ventricular endostalic volume. Volume will increase the left ventricular endostalic pressure, increase the wall tension, increased oxygen consumption, and that can lead to myocardial ischemia. So the treatment here will be giving diuretics. If the patient is on regional or a central neuraxial blockade, you give oxygen and intubate this patient. However, if the ischemia is accompanied by tachycardia and hypotension, What you have to do is you have to build up the volume quickly, give crystalloids or colloids. If the patient has been bleeding and that is the cause of hypotension and tachycardia, remember you have to give PRPC transfusion as soon as possible and maintain a transfusion trigger of at least hemoglobin of at least 10 grams percent. If infarction is imminent with little time to treat treat the cause by time using an alpha agonist by giving phenylephrine. So give phenylephrine and try to bring up the blood pressure in these patients as early as possible. There is something called prinzmetal angina or an angina which is caused by vasospasm, and that can happen with heavy smokers or in patients where there is transmural ischemia. And these are the patients who may develop life-threatening arrhythmias such as ventricular tachycardia or ventricular fibrillation. And the treatment of choice in these patients who have vasospasm is calcium channel blockers. So these and at the same time, you have to treat them as any other ischemia. So you have to give IV nitrates in these patients. Concurrent intervention with beta blockers should be given, and anticoagulation if surgery allows. So you can have STT changes because of the rapid tachycardia. So for that, you have to treat the SVT in these patients and coagulation modulation if surgery permits in these patients. So use of heparin intraoperatively for myocardial ischemia because it is a pathologic thrombosis, and if you need to reverse the ischemia and prevent further myocardial infarction or muscle damage by inhibiting the thrombosis formation. Therefore, heparin is very vital even if it is an intraoperative heparin, if it has to be given. So some severe resistant intraoperative myocardial ischemia may occur in some patients. So these are the patients in whom you may have to abort the surgery and then go for an IABP or immediately rush the patient to the cardiac surgery. Patients who are receiving chemotherapy might develop STT changes intraoperative, especially those who have adriamycin-based chemotherapy or those who have developed cardiomyopathy, those who are having too much of insult or surgical insult. Post cardiothoracic surgery, you may have STT changes, or if the patient has developed stunned myocardium. So what is a stunned myocardium? It is an ischemia with dysfunction followed by reperfusion before the death of myocardial cells. So before proper myocardial death can occur, these are the myocardium becomes stunned, but there will be reperfusion in these patients. A hibernate myocardium where there is ischemia following a chronic low flow state. So what are the post-operative considerations? Take care of the pain. You have to continue with your epidural. You may give IV pain drugs, or you may continue with the blocks, or you can use a PCA pump. You can do whatever, but take care of the pain to avoid myocardial ischemia. So in conclusion, a thorough investigation and optimization, if there is a history of coronary artery disease and risk factors have to be done. Peripheral nerve blocks and epidural anesthesia provide the least insult. GA, if you're thinking, high opioid anesthesia will have least hemodynamic alterations. And whatever anesthesia you give, keep your demand supply economics in mind before giving anesthesia. Thank you very much.
Thank you, ma'am. Thank you, ma'am. Very much knowledgeable thoughts you shared with us. And since Nair, we never meet. This one is a good session.
So I just kept some of your private practice in mind.
Yes.
So that's why I went in depth in coronary stents and, and also intraoperative STT.
Yes, ma'am. Tejas, you want to ask anything?
Madam, the considerations for antiplatelet are very much varying. Actually, the cardiologists out here, many times they tell clopidogrel to be continued.
No.
And also some say about 3 days, just 3 days before surgery.
Clopidogrel, right? If it is an emergency, see, I tell you what, clopidogrel, if it is a peripheral surgery, even I would say 3 days, you can take the risk. But I'm telling you, it's a risk.
Okay.
On paper, if you go by guidelines,
Risk.
7 days. No compromise on that. If you go by guidelines. But since you're a private practitioner, and private practitioners don't go by textbook all the time, I know that. So in such a case, if it is a peripheral surgery, then 3 days of stopping, I would still, say, okay, take a risk, but not otherwise.
What about ma'am, spinal and any neuraxial blockade? 3 days is okay.
No.
Oh.
No. Peripheral nerve blockade, which are, if you don't have a deep plexus blockade, okay, or if there is no facial block, like if you're not going for, say, tap block, or if you're not going for erector spinae block, but you're just doing a peripheral nerve block, like say hernia block, or simple peripheral block, right? Then I won't bother so much, but no, not otherwise.
3 days is also not sufficient for clopidogrel?
No. If you're doing ultrasound guided and not hitting any vessel,
no, for the neuraxial basically.
No,
Spinal
you're going blind, right? You want to do blind. No.
Because cardiologists, they say to stop only for 3 days. Then we have taken the cardiologist opinion, and they themselves they say that they will stop for only 3 days. Then the surgeon will be saying, the cardiologist is saying so and so. Whatever guideline it is, that they have to manage. Many times we delay it, but sometimes we have to do in that scenario.
See, the topic here is major non-cardiac surgery.
Yes.
Major non-cardiac surgery means patient can have fluid shifts. Okay. If you are under you should not succumb to pressure. It is 7 days. 7 days. Ask him to show the guideline for 3 days. Ask him to show. If the guideline says 3 days, you will say, okay, this is major non-cardiac surgery, no? So you should not err on that. But what I am just trying to tell you is there is something called, intermediate risk surgery, which I already mentioned, and low risk surgery, which I already mentioned. In that, if there are any peripheral surgeries, breast surgery, okay, limb surgery, all these you can take some amount of risk of 3 days. I can understand. But if it is a major, please keep platelets also ready. If you have taken the patient for within 3 days, keep platelets ready with you.
You mentioned about platelet function test, but I don't think in periphery like
not many people are doing. But the guidelines are saying you have to monitor PFA.
PFA is very difficult to
you have
to bother ask if you have to do it the PFA.
No, it's not possible. It's just that I'm just giving you the guidelines. Okay. But even in tertiary hospitals, we are not doing that. So that's not possible all the time.
Okay. Sometimes
the best you can do is, take a blood and look at the clotting time.
Okay.
That's
BTCT types.
Yeah, that's it.
Sometimes, ma'am, in the old age patient geriatrics, the diastolic systolic will be there is a wide pulse pressure, like 60, 70. Suppose it's a baseline pressure 140, 70, without any aortic wall issues or anything, just wide pulse pressure. So you said about diastolic pressure to be maintained. In such cases, if you give spinal anesthesia, the systolic will be maintaining it around 120, but diastolic will fall around 50, 60. It will fall 10 points, suppose. Then this diastolic should be considered according to the baseline, right?
Yes.
Okay.
Yes. remember, but you have to ensure that, BP doesn't fall in these patients.
Yeah.
Give phenylephrine. That will buck up the diastolic pressure.
That's it.
That is something which you have to be very careful. In ischemic heart disease, don't allow hypotension.
Hypotension, yes.
Yeah. Don't allow hypotension.
We should target the mean pressure.
You have to be very proactive when it comes to hypotension. Immediately you have to treat.
Definitely. We should target the mean pressure, right?
See, mean pressure is only going to tell you about the flow in various organs. But coronary flow is dependent on LVEDP. Remember that. Okay. Here we are looking at coronary flow.
Okay.
So take away home message was, for peripheral procedures, you cannot mean to say not to worry about that 3 days clopidogrel dose given by cardiology, but for major surgeries you should be worrisome with platelets. Yes.
Yeah.
No, madam also said for spinal epidural also you should stop for 7 days at least.
Yes. But for
central neuraxial blockade.
Yeah.
Central neuraxial blockade and facial blocks you have to stop.
For deeper nerves.
And also because you all are not using ultrasound.
Yes, ma'am.
NICERA guidelines also say the same thing.
Yes.
The region is okay.
Yes.
So overall, there will be 7 days stoppage of clopidogrel, but for private forum point of view, you can do for smaller cases or for that 3 days is sufficient. Something for peripheral, not to give deeper nerve blocks for that.
Not for prostate, not for ophthal, not for neuro, and not for spine. Remember that. Not at all.
Yes.
उसमें तो बहुत इज्जत देने का ये 4 के लिए.
I have seen many patients, ma'am, with having prostate issues, the TURP done, taken bleeding for clot evacuation after 12 hours. When we see the file, aspirin was continued and clopidogrel was stopped just 2 days back. And
that's what I'm trying to tell you.
The same thing.
Continue. See, aspirin, the thing is, don't stop aspirin.
If it's a prophylactic dose given.
But clopidogrel, you have to stop.
I know, if the aspirin is given just as a prophylaxis,
they get 75 milligram or 125 milligram. That's not much.
75.
Yeah, they don't get much of aspirin, but they get dose. Pardon?
Depend any sound you do? Depend.
I think you have to mute a few people.
Yeah, I think so. From yes, depend. Can you unmute yourself? Yeah, mute yourself, please. Yeah.
Yes.
Please, Tejas, can continue. Tejas?
Okay, ma'am. Yes, sir.
What you are asking on that point?
The same thing, the same scenario, the TURP patient and all. What madam said is.
Yes. So I think in question and answer box one, Dr. Priyanka Jadhav mentioning about amazing lecture, ma'am. It's so I feel from audience, any questions can you please want to ask? You can ask in the Q&A box, or any suggestions for that, or queries you can ask in Q&A box for madam. Okay, okay. We'll unmute you. Deepen, can you unmute Dr. Someshwar Patange, sir, please? It will be...
Yes, yes.
Yeah. Or even you can keep him panelist also, no issues. Sir is our president-elect from ISS Ibrahim Nanded. Sorry.
There is a question by Tarin Mittal.
Yes, ma'am. Yeah,
I don't
ma'am.
have phenylephrine, only Termin. Use whatever you have.
Yeah.
You can use ephedrine, you can use whatever you have. But you have to bring the BP up. That's important. But if you have phenylephrine, nothing like it, because it's a pure alpha, you know.
Yes.
Yes.
Now it is easily available by Neon now. Fenpress, less it's easily available. From Varsha
Vora,
yeah.
stoppage for 5 days for spinal for ortho surgery. Is it okay? See, I would say stop 7 days, because that's the guideline. Again, for spinal, if you're using, see, I'm talking to you as a teacher. From a medical college, I would say no, 7 days. But in private practice, 5 days, if I have to give a spinal, I will use a very thin needle. Got it? Spinal. But I would not advocate. I'm not going to advocate this, but I'm sure you people don't follow me, textbook, as I said. So if you have to use it, then use a very thin spinal needle.
Thank you, ma'am. Thank you. Please, Patange sir, you have unmuted, I think so. Dipen, you unmute Dr. Someshwar Patange.
Patange sir, yes, welcome. Yes. Nice to see you. Sir, you have to unmute yourself.
Yeah. Okay. Are you getting me?
Yes, sir.
Yeah.
Yes.
Good to see you after a long time, madam.
Yes, sir. Nice to have you here.
Yeah. Actually, one question I have. I got a call that patient is under hypotension, and they have started the symptomatic. And when I reached the BP was 140 and 90. So can I give dexmedetomidine that patient?
Can I give?
Dexmedetomidine.
Dexmed. Was the patient having tachycardia?
Laparotomy. It's a laparotomy patient.
Was there tachycardia?
Yeah, tachycardia, and patient was on symptomatic. So actually,
no. Which drug? You mean patient was on inotropic support?
Yeah, inotropic support.
Dopamine.
Yeah,
Dobutamine. Okay.
Yeah.
All
so
right.
Should I go for the dexmedetomidine?
See, dexmedetomidine, generally it decreases the heart rate, but it has got very little effect on blood pressure. But is the heart rate also very high when you're giving?
Yes. That's why I'm telling.
Then you have to give, because you have to bring down the heart rate also.
Okay. But just half an hour back, the patient was under hypertension.
I know, but now the patient is on dobutamine. Now the blood pressure is fine, but there is tachycardia.
Yeah.
So you have to give.
Okay. We can give esmolol also, no?
Yeah, but dexmed is, it also provides analgesia. And,
yeah.
And it has got very little effect on blood pressure.
And it decreases the requirement.
In fact, if you compare it with esmolol's effect on blood pressure is much, more hypotension as compared to dexmedetomidine. So I would any day go for dexmedetomidine.
Yeah, actually it decreases the requirement of opioid also.
Yes.
Yeah, so better to
I would go for it. I would go for it.
Yeah. Thank you, madam.
Thank you, sir. Sir is our president-elect, and really thank you, ma'am.
Really
for
nice.
your yes.
Yeah.
We are missing you on CME Borivali. I tried to see that you
Actually, I
didn't
had
see
been
on
to
that day.
Tirupati. I had been to Tirupati at that time.
Okay.
So, you know, the tickets were booked long before. So I just couldn't do anything about it because in Tirupati you have to do online booking and
Yes, ma'am. Nowadays and then
all that. So there was no question of canceling anything. So I had to go there.
Yeah, huge queue for darshan also. So it was a surprise, and it's our fortunate that we should go on that time. Overall, yes, sir. If you have any question, you can ask, or otherwise you can unmute yourself. Mute yourself. Even Dr. Zeenat Patwagar has mentioning that excellent talk by ma'am. I think no questions in Q&A box, if any. Tejas, you want to ask any other question for madam?
No, sir.
Okay. Tejas is a ma'am. He's a first cardiac anesthetist from our ISA Nanded City branch. He done almost 100 plus cardiac cases in bypass surgeries and all. So very
nice.
talented person, and really
keep it up. God bless.
Yeah.
Thank you, ma'am.
This time we are doing nice work from IS in Nanded, and we one of the person is doing.
You all are doing excellent job.
Yes, ma'am.
Excellent.
Yes. So we are keeping this case meets on the behalf of our celebration year. That's Platinum Jubilee celebration year. With that, our ISA Nanded City branch is on 25th year. So Platinum with Silver Jubilee year.
Wow.
So that both things are happening this year. So, and I'm the secretary.
And you have a dynamic secretary and president.
No, nothing. So, not like that.
Yeah, of course. Yes, I'm so proud of you. I'm so proud of you.
Thank you, ma'am. Thank you.
You all are doing an excellent job, no doubt about it.
Yes. We are keeping PGCon in Jan or Feb, ma'am. So we'll talk on that next time whenever time permits. Earliest from my side and or I said under city branch point of view. So I feel yes.
So you all are doing it through ISA or what is it? ISA.
Yes. Yeah. Through ISA, it's a state activity.
Yeah.
They awarded that PGCon, and even we are planning for bidding national CME. Hope so. We will get in 25th, 27th, Shillong.
Yeah. All the best.
Yes. Thank you, ma'am. I will conclude this session. Very much thank you from our ICCT branch members and Dr. Prahlad Kotkar sir and myself, Sachin, President Secretary. We really thank you on coming on this platform of our ISA case meets ICCT branch Nanded. Thank you, ma'am. Yes, thank you. So I will conclude this session. We'll send you recording of this session earliest. Thank you.